So we're going to kick off the day. I'm thrilled with Dr. Lavelle's lecture because I think it was hilariously funny and a really great setup for everything we're going to cover this whole weekend. Let's talk about the HPA axis, connecting the dots. All right, here's a reminder of everything about my lecture, but the lecture that you're going to hear about today, the rest of today, and tomorrow. So number one, not everything is absolute regardless of the literature. Now, I know a lot of you appreciate and love and claim evidence-based. I'm evidence-led. But you also run busy practices, and you have lots and lots of patients who give you feedback. And you may find something in the literature, but in your patient base, you're like, yeah, that doesn't work. That doesn't work for like, this subset of people. It's not always in the literature. So we gave a ton of references, but I fully understand not everything is absolute. Having said that, not all patients read the Merck manual. Therefore, when they come in with symptoms and complaints, or you give them something, whether it's a medication or an herb or a nutrient, and they have the complete paradoxical reaction, like they all don't respond like we think they're supposed to. So you're going to take some of this stuff, you're going to apply it with your patients, and if it doesn't work, I gave you a lot of lists of a lot of other things you can apply. The lists in this lecture are not exhaustive. You're going to see like my adaptogens lecture in my slides, and you're going to go, but you're missing this one and this one and this one. I'm like, I know, I only have 2.5 hours. We're going to get there. Like, I fully understand. And we'll have mini modules like Mark talked about that will go into some of these topics deeper. I just had to give you a smattering with the references and some suggestions. The references are provided, speaking of which, so if you're curious, please read them for more info. A few of them I will point out that are really quite good and have very cool graphics and might be really helpful for you. Utilize your supplement reps and your compounding pharmacists. I tell you what, I know they are for profit. I know they are. But what they have really great insight into is what other people are using, how they're using it, and if it's working. I can't tell you the number of times I've called my compounding pharmacist and said, what are other practitioners using for? And it's either acne or orgasms, right? Like everyone's got problems with acne or orgasms. Because I want that information. I think I know, but maybe they're like, oh, we just have this new gel out. It's this new base, and it works even better. I wouldn't have known that. Great. Or I call my supplement rep and I say, I've been using this, but are other people finding something better that sleep through the night? I have something great that they can fall asleep. What's sleep through the night? And they're like, oh, I visit 50 practices a week. I can give you that feedback on what is working. So utilize them. Remember those pillars of health that Mark just talked about. We're going to touch on them in treatment, and Dr. Lavelle went into them quite a bit. I'm just going to assume you guys know the lifestyle stuff. Like this is just the HPA axis stuff. And if you're like, well, why didn't you mention the gut? And like, why didn't you mention this? And why didn't you mention that? I'm just assuming you've got that, and we're just focusing on the HPA axis. And lastly, stress spelled backwards is desserts. This is the HPA axis talk, so we are going to try to make it not stressful. All right, let's go through a little physiology recap on how you make cortisol, where it comes from, things like this. So we are in the nervous system, of course. We are in the peripheral nervous system. Specifically, we are in the autonomic nervous system, and the autonomic nervous system gets divided up into your sympathetic, your parasympathetic, and your enteric or intrinsic. So new research, and people are really starting to lump enteric and intrinsic into that autonomic because the gut really functions on its own, right? It has its own brain. It does its own thing. It's much smarter than we are. And so they're really putting that into the autonomic. Now, that's not the point of my lecture. Gut will be an entirely different module that we do. But parasympathetic and sympathetic is where we're going to focus. So what is the HPA axis? Stress signal hits the brain. Please remember, it's any stress, as Dr. Lavelle said. Any stress. It can be physical stress, chemical stress, emotional stress. It can be actual stress, anticipated stress, imagined stress. It doesn't matter, right? So actual stress is today for all of us running around getting ready for Dutch Fest. Anticipated stress has been the last 2 weeks. So if you Dutch tested all the staff at Dutch, our cortisol awakening responses and our stress response would probably be a little heightened, if you will. Imagine stress are the people that make mountains out of molehills. You know those people. They are my mom, who doesn't watch these, so I can say that. And so she's the person who will, even if it's not going to, she's a worst case scenario person, let's put it that way. If there's a worst case scenario that's going to happen, my mom is going to think about it. And of course, it doesn't happen, ever. I haven't been kidnapped or hit by a bus or anything crazy that mom's come up with. And so, but her stress response reacts the same way. And what happens is it goes to the hypothalamus, right? And you get cortisol, or corticotropin releasing hormone, or factor. Sometimes it's called CRF. And then that goes to the pituitary, which releases ACTH. That goes to the adrenals, which where you release all your other hormones. Now, your catecholamines, norepinephrine and epinephrine, are not actually triggered by ACTH. They're triggered by a sympathetic downstream signaling. But their production, the making of catecholamines, ACTH has a hand in. So that's why they're on the list. Dr. Lavelle talked about norepinephrine and epinephrine much more than I'm going to. Our entire 90% of our focus is going to be on cortisol. A little bit's going to be on DHEA. And then there's other ones we will have in more advanced, like melatonin, norepinephrine, epinephrine, we'll have in different modules. So fight or flight. We're talking about fight or flight. And I thought this cartoon was absolutely adorable. I can't claim it. Somebody else gave it to me to put in my lecture. It says, you can fight, me, flight. So this is what we're talking about. When you're looking at the adrenal gland, it's divided into layers. As a reminder, we're talking about the cortex. We're talking about the 3 zones, and specifically, we're going to talk about cortisol. There is the medulla. That's where you make your catecholamines. So let's first focus on cortisol, and that is going to take the majority of this particular lecture. So how is cortisol made? Well, some hormones are made from circulating hormones, right? But your cortisol is not made from circulating pregnenolone or circulating progesterone. That's not where it's made. And this is really important to know in steroid biochemistry because so many people think if I give pregnenolone or I give progesterone, I will just raise their cortisol because that's how the steroid pathway looks. Please remember the steroid pathway is on a piece of paper that reflects all of your cells and all your hormones in one 8.5 by 11 sheet. It doesn't divide it up, and I'm going to go into that. Because the first step to make a hormone is where the star protein binds to cholesterol. They're called steroid hormones. Cholesterol is the backbone to all of them. It's the first step. And specifically, its cleavage by pregnenolone is by cholesterol desmolase. It's the rate-limiting step to cortisol production. Not pregnenolone, not progesterone. The other really interesting thing when I was reading this chapter in this book is that your cells in the cortex have large stores of lipids right there inside of them for steroidogenesis. And I was like, of course they do. That's brilliant. Why has that never dawned on me before? Like if the adrenal gland needs cholesterol, it's got its own little bank right there in the cells for it to pool to make cortisol. So let's go through this so you can see. Thank you to our amazing marketing department who made these little videos. I think they're the cutest things. So your brain releases ACTH. It goes around in circulation. Round and around it goes. It goes down into the adrenal gland, into the cortex of the cell, kicks the star protein binds to cholesterol, which goes into the mitochondria. Now, as far as we know, your mitochondria don't steal from each other, right? So we're talking about what's happening in the cortex of an adrenal cell. A very similar pattern is happening in the mitochondria of like a lutein cell to make progesterone, but it's not going on to make cortisol. This is happening in the cortex of the adrenal cell. Then you keep making hormone up into the endoplasmic reticulum, back around again. We got your progesterone to 11-deoxy to cortisol, and then it gets released out into circulation. Aren't these the cutest videos? All right, cortisol production. Here's what's important to know. About 70% of your cortex is specifically your fasciculata. 70%. Out of 100% of your whole cortex, 70% of it goes to the fasciculata. More so, it can be thickened, believe it or not, by repeated cell phone exposure. I have a study on that. Less than 5% of your cortisol is circulating as free. Some research says 1%, some research says 3%, some research says 5%. It's a teeny tiny number, right? Why is your cortisol only less than 5% that's free? Because your hormones are like children. They can't be unattended at any time. So your body binds it up to a binding globulin, specifically cortisol binding globulin, also known as transcortin, or albumin to a lesser percent, and that's what it circulates around in your blood. Do you guys remember what the other hormone that binds to cortisol binding globulin? Progesterone. Progesterone will bind to cortisol binding globulin. And when you think of the binding globulins, like Dr. Lavelle talked about, thyroid binding globulin, all your binding globulins act very similarly. They go up to things like the birth control pill, right? Like they all, so if we think of thyroid, but then think, oh right, SHBG and CBG all get affected by these things. Lastly, you have cortisone. Cortisone is inactive, primarily, really. It doesn't do much. We are going to talk about cortisone, but it does bind to cortisol binding globulin. When you make cortisol, you make it in the diurnal pattern. This is what Dr. Lavelle was talking about. Now, I understand some of you probably treat night shift workers, right? You have nurses, you have factory workers, you have police officers, and they work night shift, and they're like, well, what do I do for this? We completely appreciate our night shift workers. That's a whole other lecture on what to do and how to work with them as best you can. But what we're going to focus on is your daytime, what you're supposed to have, diurnal pattern. So with your diurnal pattern, we have a normal response. Your normal response is that you wake up, your cortisol kicks in. It's called the cortisol awakening response, which we will discuss. It goes up, comes down, and is really down at night before bed. Basically, you want your cortisol up to get you prepared for your day, to affect your blood sugar, right, to reduce inflammation, to give you energy, to make you alert, and down at night so that you can go to sleep and your melatonin can come out. Why is this important? This says the circadian rhythm regulation plays a crucial role in people's healthy lives affected by factors consisting of cosmic events. Like any paper that uses the word cosmic events, like I'm in, related to the universe and Earth, environmental factors, light, night, day, duration, seasons, and lifestyles. These factors changes lead to all sorts of diseases and conditions. Now, ladies and gentlemen, in my lecture, I have 2 slides that are my most favorite slides in the entire lecture. The next slide is my first favorite slide. It's that one. This is the actual slide in the paper that was referenced before. Now, this is how I anticipate it going. The researchers, and if you've seen these similar memes, you know what I'm talking about. I guarantee you the researchers were like, to their graphic design department, was like, hey, I need a graph that's out of this world. And the graphic design team was like, fam, say no more. I got you. How awesome is this? So biological clock, disharmony, takes into account mutations, lifestyle, disease, and then it goes out from there. So you can understand why this is one of my favorite, at least from a visual point of view, slides. If you get the diurnal pattern wrong, if you get your cortisol wrong, if you get your HPA axis wrong, you affect so much downstream. What do you affect? This is what cortisol does. This is why we love cortisol. I know some of you have a love-hate with cortisol, right? But it's like Goldilocks. We want not too much, not too little. It depends on the time of day. We want it to react when it's supposed to, but go back to normal. We don't want it to overreact. We don't want it to overreact for too long. So it's a very specific kind of hormone. And it does a million things. Blood sugar, metabolism. I tell people when I lecture, if you cannot get your HPA axis right, you will never get your blood sugar right, and vice versa. If you can't get your blood sugar right, you will never get your HPA axis right. They are that intertwined. They're that intertwined. And just like Dr. Lavelle said, like people come in, they just want a magic pill. In fact, I was talking to a doctor right before here who was like, everybody just wants the magic pill. No, I don't want to give up my crappy diet. No, I don't want to exercise. Can I just go on fish oil? You can, but like, hello, let's go for the cause here. So cortisol has a big impact on gluconeogenesis, glycogenolysis, how you use glucose, what's going on with your muscles, hemodynamic. It affects your arteries, right? Nervous system, modulates perception and emotion. We know this. When we get stressed out, it's entirely possible we are a little bit emotional. Maybe. cortisol has a big effect on that. Immune function. How many of you knew that cortisol is anti-inflammatory to a point? It can be very suppressive to your inflammatory cytokines, right? But if you don't get a proper HPA feedback, if you have cortisol dysregulation, then your immune fire can run wild. So it's really important, and here are all the ways it can and all the ways why. Everything from the actual inflammatory cytokines themselves to influencing your Th1, Th2. It's really, really important that we get this correct. So now that you made it, where does it go? What do you do with your cortisol now that you've made it and you've used it? So it turns out you can flip back and forth between cortisol and cortisone. Cortisone is inactive, like I said, and it's modulated by this little enzyme called 11-beta-HSD. 11-beta-HSD1 makes more cortisol. 11-beta-HSD2 makes more cortisone. And you can see the heavily concentrated areas of where each of them are. When you're looking at the cortisone side, kidneys, colon, salivary glands, there are areas with a lot of mineralocorticoid receptors. It's to protect, because you want aldosterone, right, to be on those receptors. So it's to protect, because cortisol can bind to those receptors as well and cause problems. Where do you activate to cortisol? In the liver, in your adipose tissue. This is why cortisol, like Dr. Lavelle said, and what I said in the prior slide, has a big impact on your fat cells, fat distribution, fat size, fat cell size. It has a big impact on it. And this 11-beta-HSD1 is really heavily concentrated in there. But also in the gonads, up in the brain, and your vascular smooth muscle. Now, again, it's Goldilocks. Like everyone freaks out and goes, I want to inhibit it. I want to inhibit it completely. It'll help me lose weight. I'm like, okay, hold on. Still not a magic pill. If there was a magic pill, I swear I would tell you guys. Actually, I wouldn't, because I would be a billionaire on an island somewhere. But I would at least like Skype in and tell you what it is. But there's no magic pill. It definitely comes down to lifestyle and everything that was discussed this morning. Now, when we get to the herb part, I will tell you some that have been studies to help inhibit 11-beta-HSD1, so to like lower the cortisol effect, or the opposite, to increase cortisol for those people who struggle to have it and to make it. So now that you make it, you got to metabolize it, right? So then it goes through the liver, which is irreversible, and you make THF, alpha THF, tetrahydrocortisone, or cortisol, and then tetrahydrocortisone. And once you make those, THE, and then it goes back up the other way. And this is what comes out in the urine, and this is what we test on Dutch test. And when we get to the metabolites part, I'll explain why it's so helpful and why it's really important. So quick recap, physiology and anatomy, which I know a lot of you already know, but just as a reminder, because we did start at 7 this morning. So this is the HPA axis, in case you've forgotten. We understand how cortisol is made and how cortisol is not made. We understand what it does, its physiologic effects, that there is a diurnal pattern, which is very, very important. How your cortisol and cortisone go back and forth using that 11-beta-HSD. They get metabolized in the liver, the metabolites end up in urine, and now you want to know, how do I test this? How do I test all this, right? Now, a lot of you are already using Dutch test. Some of you are not. Some of you have come from other, like you've only done saliva, you've only done serum. So how do you test this? When you look for lab-related measurements, you have a lot of options, as I just explained. You can test your free cortisol. You can test your free cortisone. You can test your metabolites. So you can find out this really big picture of what's going on downstream in your HPA axis. Of course, you can test ACTH. You can do stim tests and things like that. But knowing these downstream things at least give you a pretty good idea of active, inactive, and then production, like what's coming out through the metabolites. So we get the pattern on testing. We get your stress response or resiliency. This is the cortisol awakening response. For those of you who are unfamiliar with that, we will definitely talk about that. It's my new favorite thing. We get your total production of cortisol, that's your metabolites, and we get your preference for cortisol or cortisone. So basically, what does this tell me? This tells me, can you make it? Do you have it? How much is inactive? And what's the pattern? It's a pretty big picture to get, right? When you're talking about stress, resiliency, energy, blood sugar, cardiometabolic risk factors, sleep, with all this testing. When you test, though, you don't want to miss the diseases, the big ones. Addison's being a big one, right? This is the autoimmune, where you have very low production of cortisol and aldosterone. So here's a case of somebody with Addison's where they did a combination saliva-urine. And everything is very, very, very low. So their free salivary cortisol is near 0. Their metabolites are also near 0. So very confirmatory. Like, wow, you're near 0. Like, this is bad. We should probably get you tested. Sure enough, it was Addison's. And then you can see the pattern is that low, flat line, because there's no diurnal curve at all with Addison's. This is somebody who did it in urine, not saliva. So I know a lot of you look at Addison's in saliva. But on Dutch testing, on the Dutch Complete, you can absolutely see it in urine. Look, their free urinary cortisol is still near 0. Their urinary metabolites are still near 0. And their diurnal pattern is low and flat. No matter what, they don't make cortisol, very much of it anyway. So it's going to come out low, low, low across the board if you're doing a saliva-urine combo or if you're doing urine for free cortisol and the metabolites. So what about Cushing's? Can't miss Cushing's, don't miss Cushing's. Cushing's syndrome, likely due to steroid use. Cushing's disease, a tumor. What does that look like? This is an example of an actual Cushing's patient who ran Dutch test, and we were like, you might want to get tested. So their salivary cortisol is really pretty high. Their urinary metabolites confirm the elevation, and then they have this really high, not really a diurnal pattern, kind of all over the board pattern. Why don't people with Cushing's and Addison's have diurnal patterns? Because that HPA axis communication isn't there. And if it's Cushing's tumors don't follow a diurnal pattern, right? So it's going to be usually really high and usually on the flatter side. It's not going to go up and then down. Tumors don't go to sleep, so it'll look crazy in this example. Sent them for testing, turned out to be Cushing's. The thing with functional endocrinology, which I think is why you all are here, right? FEST, we're having a FEST, Functional Endocrine Summit. And I'll be honest, when we first came up with the idea, I was like, Dutch Fest, I want swag. Like, I want a hat or a hoodie or something, right, that says Dutch Fest on it. So the focus on functional endocrinology is different than the extremes. It goes beyond Addison's and it goes beyond Cushing's. Because what if you have high free cortisol but low metabolized? What if you have high metabolized and low free? That's not Addison's and that's not Cushing's and it's sure not normal, so where are you? So functional endocrinology, which is what we call it, and a lot of you call it, is that you don't want to miss the disease states. Don't miss it. But what you're most commonly going to see in your office are the generalized HPA axis dysfunction, right? And you have to address that. So conventional or traditional endocrinology says you are one of these 3 things. You are Addison's, you are Cushing's, or you are normal. And how many of your patients come in and go, I went to the doctor, I don't feel normal, and they ran my blood work, and they told me I'm normal. Or we did all this research, I think it's the adrenals, they told me it's not Addison's, I'm normal. It's not. So we came up with, actually Mark came up with this, the functional endocrinology model. So I call this the Newman spectrum of functional endocrinology. So it's a spectrum, right? You have Addison's and Cushing's on either side, and then you've kind of got this adaptive cortisol, like you're trying to adapt to your situation, and you're maybe not adapting that well. And you're not rebounding that well. And so you're not quite normal. You're more on the adaptive side, or you're high adaptive, or you're low adaptive. So it's this sliding spectrum, and we're going to talk about that. What is the acute response, though, when we're talking about adaptive? So here's the acute response. So the regulatory mechanisms are functioning well, and you're trying to maintain homeostasis. So we put this in a graph, and you'll see the person with the shock face. Oh, there's a stress. Oh, no. And then, the lightning bolt strikes, because that's what happens when you have stress. And you get this sympathetic stress reaction. You get the parasympathetic rebound. And now you're back to a smiley face. You go back to normal, which is like what we hope for, right? But what happens if you have chronic stress? Or not even chronic stress. What if you have repeat acute stresses? And what I call these patients are the and-then patients. How many of you have and-then patients? Right, you already know what I'm talking about. I don't even have to explain it. So these are the patients where you go, so when did it all start? They're like, oh, well, it started when I graduated from medical school. And then I did my residency. And then we sold our house. and then we moved, and then I got pregnant, and then, right? It's the and then people. So there is a triggering event, the acute stress, or maybe it's something, I got in a car accident. You know, it wasn't like long and prolonged like school. It was, I got in a car accident. And then they pause, and they're like, and then they just keep going. So these are your and then people. And what happens with your and then people is the lightning bolt strikes, and they get this strong sympathetic response because they've already had acute stressors, and homeostasis has kind of gone out the window, and their parasympathetic can't quite get up there, right? And so now they have a failure to recover to normal. And these are the majority of the people that are walking into your office. And I'm sorry, it's probably the majority of people sitting in this room. You know, I'm sure if you, I mean, I know it's me. I read you my phone that told me I needed to take a break. I was like, shut up, Ring. I don't have time for this. I popped my adaptogens this morning, my fish oil, my B vitamins. Just take a pill. So everything I just said, this is the spectrum. This is the HPA axis to spectrum, just listed out. So you have an acute stressor. Your body reacts normally, you rebound, you recover, you take care of yourself, hashtag self-care, and you move on. Except you don't, and then it continues into this, the stress persists, or you have multiple and thens, then you get into this adaptive to chronic high cortisol state. You're always kind of running on the high side. But over time, the feedback loop kicks in. And now instead of being high, the feedback loop kicks in and you've dropped low. Your CRH gets downregulated, your ACTH gets downregulated, your tissues, your receptors become desensitized, and it can be a problem. So that's what this adaptive cortisol is. It's like dysfunction that's not quite high, it's not quite low, but you know it's not normal, it's not Addison's, it's not Cushing's, and that's what we're really going to talk through, this adaptive. So let's talk about high cortisol. Potential high cortisol causes, these seem pretty, like standard. I'm sure you guys could have repeated these in your sleep. So cortisol supplementation, always ask. It's amazing to me to find out what patients don't tell you. It's amazing to me, working at a lab, when people fill out the requisition form, their form about them, their name, their birth date, their address, yes, I want this Dutch test. And then, these are my symptoms, these are my medications. And it's amazing the number of times to me that I'm on the phone with you, and I'm like, well, it says here they're on the birth control pill. And you're like, no, they're not. Like, yeah, it's in their handwriting. Yeah, they are. Because they see multiple providers, or they forget. They just think it's normal. Or somebody else put them on cortisol supplementation that they're seeing, and they come to see you, and they forget that they're on it. So just ask. Stress, acute inflammation, Dr. Lavelle really, really hit that home. I love that. Inflammation is huge, and it can be anything, like I have pain, infection, think of the stealth or overt. It doesn't have to be a major, oh, I hurt my knee, I fell and hurt my knee. It could be biotoxin. It could be Lyme, right? It could be Epstein-Barr, cytomegalovirus. I mean, it could be these stealth LPS, metabolic endotoxemia from LPS, these stealth inflammatory parts that really affect your HPA. Blood sugar and insulin dysregulation makes sense. Caffeine stimulant use. Poor sleep hygiene, which he talked about a lot, and it's so critical. Hyperthyroidism, and then Cushing's syndrome or disease. High cortisol signs and symptoms. These all make sense. The one I do want to point out, though, is the fatigue. If you have high cortisol, and I get this question a lot working for a lab, my patient's exhausted, but their cortisol's high. That doesn't make sense. Couple things. Cortisol is not the only hormone that causes fatigue. Second of all, it's exhausting fighting a fight, right? So you can be quite tired. And the third thing, as Dr. Lavelle said, brain inflammation makes you feel fatigued. So absolutely, your patient can have a lot of fatigue. And when they question you and go, but I'm so tired, why is my cortisol high? You can point out these three things. Pain, increased blood pressure, like he talked about, GI issues, which we'll go into with comorbidities, vasomotor symptoms. How many of your perimenopausal and menopausal women thought their symptoms were improved? They call you or come in and go, my hot flashes are back. What's the first question you're going to ask them? How's your stress been lately? 9 times out of 10, they have an and then. Oh my gosh, this happened, and then this happened, and then this happened. Like, okay. Is it their estrogen and progesterone? It's probably their cortisol is the base of all of it. And their norepinephrine, epinephrine. Huge role in vasomotor symptoms. Metabolism issues, weight, carb cravings, Dr. Lavelle talked about, hair loss. Lots of patients come in for hair loss, right? They have major stresses. They just went through a divorce. Their daughter got married. Something happened at work. They lost their job. Their hair falls out, and they freak out. Very common. Your hair follicles have their own little mini HPA axis in them. Do you know that? Isn't that cool? Cool if you have your hair. Not cool if you don't have your hair, if you're stressed out. But yeah, your hair follicles have their own little HPA axis in them. Brain fog, memory issues, which has been talked about, and immunity issues. So let's talk about comorbidities when it comes to high cortisol, because I think this is really quite important. Melancholic depression. How many of you understand the difference between melancholic depression and atypical depression? I love the two doctors in the back, yes. Have their hands up, of course you do. So melancholic depression is dysphoric hyperarousal. These are the people who don't get excited about anything. Nothing gets them excited, which is different from atypical, which we will talk about in a bit. Atypical, they can get excited. Depression is just sort of their like running low-grade MO. With dysphoric hyperarousal and relative immunosuppression, so they have innate and T helper cell-directed immunosuppression. So not only are they depressed, but they have immunity issues, which is like a double whammy against them. It increases in certain cancers and infections, signs and symptoms, anhedonia. It's anhedonia all the time, no matter what. Like the greatest thing in the world could happen, and they're like, oh, that's great. Okay, I actually don't want to leave. I'm actually cool. I don't want to leave the house. So that's melancholic depression. That's ongoing. Anxiety, insomnia, loss of appetite, depression, worse in the morning. Worse in the morning. Huge cortisol tie. Huge. That's why it's a comorbidity to high cortisol, especially high cortisol in the morning. With melancholic depression, you get hyperactivity. It leads to glucocorticoid receptor desensitization. So the high cortisol is coming out, and the glucocorticoid receptors are like, no, don't touch me. And they don't react, or they downregulate. Sequelae being osteoporosis, metabolic syndrome, coronary artery disease. You also have decreased BDNF with depression, specifically with this depression. So here's an example of how this high cortisol can affect your serotonin production and down the kynurenine pathway, which Dr. Lavelle talked about. So when you make tryptophan, it splits, and a small percentage goes towards serotonin production, which is primarily in the gut, and then the rest of it goes down the other pathway, down the kynurenine pathway. Now, the small pathway that goes to serotonin, I was actually reading, I was told it was 5%, and then it might even be this paper that says it's about 5% that goes that way in the gut. And so 5% is like a tiny percent. And if you screw with it and you go down to 4% or 3%, like you're going to really affect your serotonin and eventually, potentially, your melatonin production as well. And other things that will divert your pathway are being estradiol, excess estradiol, inflammation, and LPS being lipopolysaccharides made from gram-negative bacteria. When it's in the gut, it's like, oh, it's gram-negative bacteria in the gut. When it gets out and crosses through your tight junctions, then it's metabolic endotoxemia. And the research on metabolic endotoxemia is crazy scary because we think worst case scenario, sepsis. My patients don't have sepsis. No, it can absolutely happen to like the average leaky gut person who's super inflamed. So if it's not treated, unfortunately, these people have a decreased life expectancy. They're at risk for so many things. And if we already know that cortisol could be a big player for them, let's address their cortisol. But SSRIs do blunt that HPA axis response. So I know there's a lot of controversy around SSRIs. Should you give it? Should you not? There's some books out there, right? Some famous folk who are like not in favor of SSRIs. But if you need it, use it. I've had many a suicidal patient, super depressed patient, the SSRI changed their life. If you need it, use it. What it also does is it increases BDNF. SSRIs increase BDNF. And unfortunately, though, here's the kicker. There's treatment resistance in about 20 to 30% of patients. What I want to do, this paper at the bottom, I want to point out, stress and the gut-brain axis, regulation by the microbiome, Really good paper, highly recommend it. So for you over here, stress and the gut-brain axis, highly recommend it just to explain, if you're like new to the whole gut-brain axis thing and stress, or if you understand it but you kind of want more like sciencey, technical, nerdy, cool stuff that gets you excited, like it's a good paper to walk you through exactly what cortisol does to the gut. Everything from the tight junctions to your mucus layer, it just really, inflammatory cytokines, so I recommend it. So let's touch on BDNF, just as a reminder for maybe some of you who don't know, brain-derived neurotrophic factor. It is important for neuronal survival and development. And as Dr. Lavelle talked about, like your brain health is affected by so many things, and he talked about like the microglia and things like that. So getting BDNF up there can be really, really helpful. It protects against glutamate toxicity. We need some glutamate. It helps with memory and learning. It's not all bad. But too much, and now we do have toxicity. It kills brain cells, and that's a problem. It's a big player in synaptic plasticity and neurotransmitter release. That's important. Heavily concentrated in the hippocampus. That's your memory, your long-term, or your learning and long-term memory. But it is also made by some of your immune system cells. Look at that, platelets, T cells, monocytes, and macrophages. Unfortunately, it is downregulated by cortisol. Hypercortisolism will downregulate the production of your BDNF. We will talk about ways to increase your BDNF if you're not familiar, including some herbs that they've done some pretty cool research on that will help increase BDNF. How do you downregulate, or what's it associated with? Depression, which is what we're talking about. Alzheimer's disease and other neurodegenerative diseases. PTSD and epilepsy. So get your BDNF up there. All right, going back to the melancholic depression, when it comes to SSRIs, and there's treatment resistance in about 20 to 30% of people, could you also consider treating them from a functional point of view? Could you also consider addressing their cortisol, supporting their gut, right? Supporting the inflammation, supporting the brain, and it may make a world of difference. Use the SSRI if you need to, but also understand it's a comorbidity of high cortisol. What about GI? We talked about GI. Cortisol does a lot to the gut. It does a lot to the layer of your intestines. It affects your mucus layer. It affects your tight junctions. It affects the inflammatory cytokines in there. Elevated cortisol contributes to the chronic low-grade inflammation seen in patients with significant dysbiosis, as in IBS. Now, speaking of IBS, the data's mixed. And especially, I think, when it comes to IBS, I think, like the causes can be so varied. There can be a lot of things involved with IBS, but they kind of slant towards HPA axis dysfunction with IBS. And we know that when people get stressed out, some very affected people, they immediately goes to their GI tract, right? They'll get cramps or they'll get diarrhea. Their stomach hurts when they're stressed out. Little kids, when they get stressed out, their stomach hurts. Well, some adults too, their stomach hurts. They get heartburn when they're stressed out. So it absolutely plays a role. What about ovulatory issues? Of course. You can't exactly be reproducing if you are running from the tiger. It's does it say here? Yeah, survival over reproductive activities. So what happens is when you have low GnRH, you don't make FSH and you don't make LH, and cortisol has a big role, a big negative feedback role in this. So with ovulatory issues, it runs the gamut. You might have somebody who just has luteal insufficiency, complete anovulation, exercise-induced amenorrhea. I had a patient who loved to run marathons. Every weekend, she ran a marathon or a half marathon. God bless her. Sounds like hell to me. But that's what she liked to do, and she couldn't figure out why she couldn't get pregnant. I was like, hold on. You can't figure it out? You run a marathon every single weekend, you travel all over the United States doing this, and you can't figure it out? When she stopped running, within a couple of months, her cycle normalized, and she was able to get pregnant. PCOS, Dr. Gersh is going to talk about, our expert here. And resolution of high cortisol can absolutely lead to the spontaneous recovery of ovulation. And I'm sure women or men with women in their lives, it's like it happens to you. Some people, like when they travel, right? When they switch time zones, when they go through a very stressful time, it affects their cycle. It might be heavier. It might be longer. It might be shorter. They may just skip a cycle, It may really affect their PMS, how much they bleed, their pain, their mood, all of those things. Last year, I travel a lot for Dutch and do a lot of lecturing for them. So last year, in the span of about 6 to 8 weeks, I flew from Portland to LA to Sydney, Australia. I lectured in Sydney. I flew to Perth, which is on the other, Sydney and Perth on the opposite side of each other in Australia. And if you don't know, I know you know, but if you don't know, Australia is a really big country. It's a very long flight. I lectured in Perth, flew back to Sydney, lectured again in Sydney, flew to New Zealand, to Auckland, New Zealand. I did a half-day lecture in New Zealand, got a cold, imagine that. Flew back to Sydney, flew back to LA, flew back to Portland on a Monday. On Thursday, I flew to San Diego, lectured on Friday, flew back to Portland on a Sunday, and then that next Friday, I flew to Johannesburg, South Africa, where I lectured in Johannesburg and then on to Cape Town. You think I had ovulatory issues? I can assure you, I was maybe not the pleasantest person around the ovulatory time because my cycle, my HPO axis and my HPA axis were like, girlfriend, what are you doing? Knock it off. Once I flew back from South Africa, I didn't travel for a little bit, not much, and like everything regulated again. Like once I was on a normal schedule in a normal time zone and, you know, like not as stressed and like no amount of rhodiola in the world was going to fix me, right? Like I needed to fix the cause, which was I went from this side of the world to this side of the world and back again, and that was the problem. So when you're talking to your patients about their ovulatory issues and they won't deal with their stress and they just want the pill or they want Chase Tree to bring on their ovulation, like just think about this. Stress has a huge impact. This is what ovulation is supposed to look like. This is a Dutch cycle mapping. On a cycle mapping, the black dotted lines are where you're supposed to be. The red and blue line are the patient. So, let's see here. There we go. So, red and blue are the patient, black are the reference ranges. So that person is ovulating. They're like textbook perfect. They read the manual. Their ovaries are like, got it. I make progesterone pretty solidly, come down, get a period, no problem. The person on your right is an anovulatory cycle, hence the frowny face. They have a flat line for progesterone. They do not ovulate. So remember, cortisol is not stealing progesterone. The mitochondria and endoplasmic reticulum of the cortex of the adrenal cells are not stealing out of the mitochondria and the endoplasmic reticulum of the lutein cells. It starts where the star protein comes in and binds cholesterol and goes from there. However, as you know, cortisol plays a big role in affecting your FSH and LH. There is a feedback loop. Glucocorticoids will downregulate GnRH. That will downregulate LH and FSH. But sometimes it's not across the board because higher frequency, more often pulses favors LH. As you're gearing up to ovulate, your body gets really excited, and so it like makes the pulses come more often. And then when you're not about to ovulate, like they slow down, right? And they make estrogen. So if you have a lot of cortisol, it might be enough to suppress the fast high ones to more of a slow, and now you're making FSH, so you make estradiol, but the LH is like not going to be favored. FSH is. And so you do definitely see people who are high stress don't ovulate with high estradiol. And you're like, well, riddle me that, Carrie. And I'm like, because it depends on the GnRH pulses. If you slow the pulse down, you will make estradiol. If you speed it up higher, you will make progesterone. And if you mess with the system, then the body doesn't know what to do and might not do either. All right, impaired memory. We have all had bad stress where we thought to ourselves, I think I have early onset dementia. I can't remember where I put my keys, what his name was, or anything on my to-do list. And then the stress ends, and it turns out we did not have early onset dementia, we just had major stresses. Or you have your patients come in who are going through big stress, job change, moving, divorce, just had a baby, and they're like, I have dementia. I'm like, you don't have dementia. You just have a cortisol-affected hippocampus and the rest of your brain. Cortisol crosses the blood-brain barrier. It affects your hippocampus, amygdala, and frontal lobe. High concentrations of cortisol have been seen in individuals with hippocampal atrophy. The hippocampus is also what affects your cortisol awakening response. They have a very tight relationship. But if you lose cells in the hippocampus, you're going to struggle with memory and recall. Long-term exposure to endogenous cortisol, memory impairment. We know this. With aging is associated with smaller hippocampal volume, death of the neurons, and cognitive decline. Now, if you have an and then patient who never stops and doesn't take care of themselves and doesn't address it and support their brain and get their BDNF up, their choline, and all these things, absolutely they could lead to big-time cognitive decline. So when I joke about the things like, have you ever had a high stress and think you're in early onset dementia? I don't mean to poke fun at it, but it's the cortisol has a big impact, but if you can go back to normal, requires a lot of work on your part or your patient's part, but with long-term exposure, you can have big-time problems. All right, low cortisol comorbidities. I love this picture because it's a girl in yoga pants and a hoodie, and I was like, oh, there I am, just not with blonde hair. So, potential low cortisol causes, long-term stress and burnout. We're going to talk about burnout. Sleep dysregulation, which Dr. Lavelle talked about. Hypothyroidism, which when we get to the metabolites will make a lot more sense. Medications. It's amazing to me, like I said earlier, the amount of patients on medications that forget to tell you. Glucocorticosteroids make sense. They're on prednisone. It's the feedback loop. You will shut down their own endogenous cortisol production. But what about opioids? We have an opioid epidemic in the United States. I had a practitioner email me, irate, this is a couple years ago, and he said, I have this young man, and all of his hormones are low, all of them. Your test is wrong, and I demand a repeat. And I was like, okay. So when I pulled up the results, they looked like something was suppressing them. I knew something was wrong. So I wrote the doctor back, and I said, hey, I will totally repeat your patient, no problem. I just need you to call him and ask him if he is on steroids, opioids, Accutane, and the doctor wrote back, I'm his doctor. I have prescribed none of those things, but I will call him. Like an hour later, the doctor wrote back, so he does recreational opioids a couple times a week. Y'all, I don't do drugs. I've never done drugs. I didn't know recreational opioids was a thing. So I was like, oh, okay. So it turns out opioids are massively powerful, which is why we have an epidemic. Too much will kill you, but not too much that you don't die, but too much it makes an impact will shut down all of your axes, your HPA, HPO, HPG, all of them. So don't test a patient post-surgery if the surgeon puts them on opioids. And if they're on opioids for whatever reason, be aware it probably has shut down all their axes. Accutane. I had a practitioner email me, this was years ago, and she said, we didn't know the patient was on Accutane. Her cortisol very low, looked Addison's. Sent it to an endocrinologist. The endocrinologist said, no, it's pseudo-Addison's due to Accutane, or isotretinoin, for acne. And I was like, pseudo-Addison's? I had never heard that before, and I didn't know Accutane did that. Sure enough, I look in the literature, Accutane can affect the cells of the hypothalamus. It can kill them. Sometimes it's reversible, sometimes it's not. So I've been lecturing about this, and I have had more people come up to me and say, that was me. I took Accutane in my 20s, and my brain has never been the same since. My hormones aren't the same, my adrenals aren't the same, or my kid. My kid started Accutane, and they're not the same. Their mood has changed, they're tired all the time. There's a problem since learning about this with Accutane. Does it affect everybody? No. But if it does affect those people, it affects them in a big way, so be aware. Aspirin will downregulate ACTH. So if you're doing cortisol testing, be careful they don't do it while they're taking aspirin. And it's aspirin, full dose aspirin. Their study, it was like a standard dose of aspirin, like people take, what was the dose? Anyway, and I thought, I was, not like, but they did it on a specific dose, milligram dose of aspirin in the study, and they did it one time. They're like, one dose at this amount, decreases ACTH. Think about the people that take a baby aspirin every day. And I don't know, because they didn't do this in the study, does it build up? Like, does it affect it a little bit over time? Over time, is it a problem? Or is it just the people who are like, ouch, my head hurts, I'm gonna take a huge dose of aspirin? The study was the one-time bigger dose, but I'm careful with those baby dose aspirin people and cortisol. I'm curious. So TBI, of course, tumors, non-classical congenital adrenal hyperplasia, which we'll touch on a little later, surgical removal of the adrenal gland, and of course, Addison's disease. So low cortisol signs and symptoms, I think these are pretty straightforward. Fatigue, sleep dysregulation, feeling unmotivated, allergies, anorexia, blood pressure issues, low libido, paralyzed by fear, stress-induced fatigue, which we've talked about. You can go either way when it comes to high cortisol, low cortisol. Fatigue is an issue. So let's jump into the comorbidities of low cortisol. Workplace burnout. How many of y'all knew workplace burnout was originally designed for healthcare practitioners? Yeah. So it is now going to be a part of ICD-10. It's a phenomenon, not a disease. And it's characterized by feelings of low energy, exhaustion, increased mental distance from one's job, or feeling of negativism, cynicism related to one's job, and reduced professional efficacy. So what can this lead to? Well, unfortunately, it can lead to anxiety, depression, fatigue, and insomnia, which makes sense. But it can also lead to cardiovascular disease. And it can also lead to increased suicide and suicide ideation. And it can also cause people, especially in some of the studies I was reading, increased alcohol use. Makes sense, right? People need to use their crutch. And then drug use, both illicit or legal drug use with workplace burnout. So it is definitely a comorbidity of cortisol. So as it is about practitioners, please heal thyself. Do not get yourself diagnosed with this ICD-10. So this is me trying to excel in my career, maintain a social life, drink enough water, exercise, text everyone back, stay sane, survive, and be happy. Don't be this person. Don't be Cruella. All right, what about atypical depression? We talked about atypical depression as it relates to melancholic depression. Atypical is when you are depressed, but you can mount excitement and joy for something that's exciting. You haven't lost complete enthusiasm for the things in your life that brought you joy. Now, it may not bring you as much joy, and you may not mount as much enthusiasm, but you can still muster a yeah, sure, I'll go to my niece's graduation. That sounds fun, as opposed to somebody who is complete anhedonia. Now, atypical depression is not as easily characterized as melancholic. Melancholic was much easier to be characterized. But symptoms, they feel better in the morning. If they're more depressed in the morning, think melancholic. If they're better in the morning, atypical. Now, it's not always absolute. Some patients are depressed all day. Lethargy, fatigue, excessive sleepiness, increased food intake, weight gain, sense of disconnectedness and emptiness, unhinged immune system with increased autoimmune risk, and a chronic low-grade inflammatory state. This is low cortisol. This is brought on by low cortisol, right? And low cortisol is really important for the immune system and anti-inflammatory. So I like the word that in unhinged immune system. You need that cortisol. With atypical depression, is early onset and is more frequently chronic. I think this is what probably the majority of your depressive patients come in with, especially if you're not in a mental health type practice exclusively. The patients who come in will probably say, I have depression, and when you ask them about the things that bring you joy, do they bring you joy? And they're like, yeah, not as much, but yeah, they do. Which is the difference, right, between melancholy. Significantly higher incidence of childhood and adolescent adverse life events. The etiology is secondary to HPA-axis downregulation and CRH deficiency. There is a feedback loop where cortisol comes up and inhibits your CRH, ACTH, and then cortisol. Chronic fatigue syndrome, common, right? People getting diagnosed or have come into your office with a diagnosis, or they've read a book or looked online and they're like, I think I have chronic fatigue. So HPA-axis dysregulation, they think, plays a key role when it comes to chronic fatigue. They've decreased cortisol activity, lower cortisol stress reactivity. They're not as resilient. Early life stress, early childhood trauma might play a role. Emotional neglect, a history of emotional neglect, they seem plays a role. Reduced HPA reactivity, which is related when it comes to chronic fatigue. Fibromyalgia, somewhat similar. Adverse childhood events, high levels of subjective stress, And most agree that fibromyalgia is associated with hypocortisolism, low cortisol. So definitely, if you get that chronic fatigue patient, your fibromyalgia patient, test them, test their cortisol. Depressive patient, like it plays a huge role. Not everything is about serotonin or dopamine. Cortisol plays a huge role. Panic disorder, PTSD, very similar. Panic and PTSD share common symptoms, and existing literature suggests similar diurnal patterns, which I show you in the next slide. Data for both is mixed, but they kind of favor a hypocortisol state. At the bottom slide there, because the longitudinal data for both disorders are unclear, if it's initially a hypercortisol, and then because of that feedback loop, it becomes a hypocortisol. So you may get somebody who's a recent PTSD, and they're in a hypercortisol state, or somebody who's had a history of it, and because of the feedback, they're jumping into a lower cortisol. This is an example. This is the cortisol awakening response that is lower than the control. So the cortisol awakening response is the red arrow, and the control, is the blue arrow, which is much higher. Now, research generally agrees that with PTSD, overall cortisol is low, but I thought this was a really good example because it really shows the difference between the blue arrow on the top and the red arrow on the bottom of how much of a difference that resiliency is. So the person in this example, they have resiliency. They can make a response. There's still communication, but it's just not that much that good, right? They've like less flexibility. They have less power behind their cortisol awakening response. And as a result, it's connected with their PTSD. So when you have these patients, test their cortisol. Again, not everything is serotonin and dopamine and things like that. These have a big role. Adverse childhood events, not necessarily a comorbidity, but we wanted to put it here to get the point across because it is linked to so many of these low cortisol comorbidities. So compelling evidence suggests that childhood trauma is a major risk factor for the development of mood and anxiety disorders, medical diseases like heart disease, and disorders such as chronic fatigue and pain syndrome. So ask your patients. How many of you ask your patients about adverse childhood events? Maybe not in the first visit, I get that, but eventually, yeah, like the majority of the room like raise their hand. Childhood trauma has been associated with reduced HPA control, increased sensitivity to the feedback loop in others. Activating the feedback loop over time. The same thing with PTSD, like initially they might have higher cortisol and over time it becomes low cortisol. So if you're working with those who have adverse childhood events and as adults, and you see they have high cortisol and you're like, well, Carrie said it was low. But remember, you don't know where they are in that spectrum. So just keep that spectrum in mind. But hippocampal atrophy results in a lower cortisol awakening response because the hippocampus is what controls the release of your cortisol, like that power cortisol, first thing in the morning. And we know people tend to have hypervigilance, more fear, and anxiety. Lastly, let's talk about a flat cortisol slope, which Dr. Lavelle talked about. Now, he talked about it a little bit different. I'm going to talk about it in the way of breast cancer. This is why I love running the Dutch test on cancer patients, breast cancer patients, because we can give them so much information. Research shows that if you have a flat slope, you've increased breast cancer incidence and poorer prognosis and shorter survival times. This is really important. You'll also get other great information on the Dutch test, like 8-hydroxy-2-deoxyguanosine, the DNA damage marker, your estrogen metabolism, right, melatonin. You're going to get all these other great things, but if I see a breast cancer patient with a flat slope and I'm consulting with the practitioner, I'm like, hey, this is a problem. Like, there's research papers to show this. We have to address this. It is a long-term prognostic indicator. Your cortisol slope. How easy to test their cortisol slope? Like Dr. Lavelle said, your flat slope is greatly associated with cardiovascular disease. Lots of studies on this. Increased all-cause mortality, primarily due to increased cardiovascular mortality. Type 2 diabetes and obesity. The flat slope with obesity is often, generally, can be the higher PM cortisol. So they have diurnal cortisol pattern dysregulation and sleep issues. And as Dr. Lavelle talked quite a bit about sleep's effect on insulin, glucose, receptors, the pancreas, so many things, it's definitely linked to obesity. So what is the goal of lab assessment? Well, obviously we want to rule out disease. Make sure you don't miss Addison's and Cushing's when it comes to cortisol. But then you want to move on to this. You want to move on to find out where are they on this theoretical spectrum. Are they adaptive? Are they low level? Are they high level? Like, what's going on for them? And how do we test the HPA axis? How do we look at it, and what markers can we measure? Obviously, you're at Dush Fest, so we're going to walk through some of this stuff. So you have options, saliva, serum, and urine, and I'm going to go ahead and just cross serum out. Why don't I like serum for cortisol testing? Because it's a combination of bound and free, right? And you don't know in that blood what's going on in that moment. So you don't get free cortisol, you don't get the metabolites, you don't get the rhythm, you don't get cortisone. You get a cortisol number, don't get me wrong, but you don't understand like the bigger picture. So that moves us to saliva and urine. Saliva was created, of course, because you could get the circadian rhythm, the diurnal rhythm, and then urine came along, and you can also get the diurnal rhythm, plus you can get some other really cool things. So with saliva, you get that free cortisol. With saliva, you absolutely get the rhythm. That's why it was created. You get the cortisol awakening response. You can only get the cortisol awakening response in saliva because you have to do it at precise times, which we'll talk about. Unfortunately, though, you can't get metabolized cortisol, so you're not going to get information about their production and metabolism, which goes a lot with certain conditions and gives you some insight into other markers you need to be testing. You can get the androgens, your DHEA, DHEAS. You can get melatonin. And of course, you don't get your organic acids, so like VMA, so vinyl mandolate or vinyl mandelic acid, which is your norepinephrine and epinephrine metabolite, right? It's metabolized via COMT and MAO. You also don't get cortisone on saliva, which I might have said. With urine, you do get the free cortisol, of course. You do get the circadian rhythm, just like saliva. You cannot get the cortisol awakening response. You don't get the cortisol awakening response in urine. But you do get the metabolized cortisol. That's where you get it. You get it from urine. It does report androgens. You get melatonin. You get your VMA. So you get your organic acids in urine testing, and you will get cortisone as well. And if you put the two of them together, you get everything. If you do if you do a combination, saliva and urine testing, then it's like the best of both worlds all in one. You cover all of your bases. Now, people will say to me, well, Carrie, why don't I get the cortisol awakening response in urine? Isn't it in there anyway? Like, isn't it the first part of the morning, which is what I'm collecting, right? I urinate on these little strips 4 times in the day. Surely it's in there somewhere, right? So the cortisol awakening response is really important because it's your mini stress test of your day. It happens in the morning regardless as if you're stressed or not. There's a research paper I read about it that said the cortisol awakening response is in response to your eventualities. Like, that is the best word ever. Eventualities, like how cool, okay. But it is influenced by stress and sleep and diet and blood sugar. I mean, it is influenced by all these things, absolutely. But it's gonna happen no matter what, and it's a really, really, really good test for your resiliency. How resilient are you? Can you even mount a response? Cortisol does go up in the second half of the night. I fully realize that, because, right, melatonin goes down, and then melatonin comes out, and then melatonin goes down, and then cortisol starts to come out. But the rise in cortisol in the second half of the night is different, specifically different than your cortisol awakening response. Why is that? Because this is the cortisol awakening response. You have 20 to 30 minutes to get up, to get that rise in cortisol. It's a survival mechanism. You wake up and open your eyes and hope you're not going to get eaten wherever you're laying, right? Or sleeping, or the cave you're in. Like, the body's like, we got to move fast. We got to move fast. So you only have about 30 minutes. Then it drops back down. This is the cortisol awakening response. Within 6 minutes, you should go up, then down. For those of you who are not from Portland, and you may not have noticed because yesterday, so rare, it rained yesterday, very random. We're surrounded by mountains, and the 3 main mountains we see all the time are Mount Adams, Mount St. Helens, and Mount Hood. Mount Adams is rounded. Mount St. Helens blew her top a long time ago, so she has a crater. Mount Hood is very pointy. So when we're looking at the cortisol awakening response, I need to know how much of a Mount Hood can you make. I want it pointy. I don't want a Mount St. Helens where you've got a dip. I want a pointy mountain. That's what I'm looking for. But I only want a pointy mountain like within a certain range, going up at a certain percent, and to make sure you fall into the reference range. There's a lot that goes into your cortisol awakening response to make it pretty healthy. But when it's unhealthy, it tells me a lot of information about you, and then I can help you. So going back to my original question, why can't I get the cortisol awakening response in urine? Why do I have to do it in saliva? It's because in urine, when we look at that waking point in the morning, your waking point is all the cortisol that you have made through the night that ends up in your bladder, and then you urinate it out on waking. That's not your cortisol awakening response. Your cortisol awakening response is from waking up to 30 minutes. I need to know right at waking, bang, and I need to know 30 minutes later, bang. Not like what you made through the night, and then 2 hours later. So the 2 hour later point does include the cortisol awakening response, but it's not very specific. And in some of your patients that are really struggling with morning stuff, anxiety, panic, depression, fatigue, autoimmune, inflammation, pain, I want to know what the cortisol awakening response is right in the morning. So how does the car work? This is cool. When you are sleeping, your pituitary gland and your adrenals are talking to each other. And your pituitary is like, now. Cortisol, or your adrenals are like, not now, nope. So the receptors are blunted, ACTH, there's a blunting for ACTH. As soon as you open up your eyes in the morning, the adrenal glands go, okay, now, go. And so the ACTH binds to the receptors, and poof, you make cortisol. What happens is that you switch from conscious to alert. How many of you wake up in the morning and feel conscious, and then like 3 hours later after some coffee, you feel alert? Right? And so, your car is not very healthy. In 20 to 30 minutes, you should be alert. Without caffeine. On your own accord, you should be alert. Then, as cortisol rises sharply, about a 50% incline at about 30 minutes, after that 30-ish minutes, it then starts to decline. Light is a triggering factor for your car. Light. Sunlight, full spectrum light, big trigger for your car. So for those of you who sleep with blackout curtains and you struggle to get up in the morning, open your curtains when your alarm goes off. Do not lay in bed and play on your phone and try to muster up the energy to go. Just get out of bed and open your curtains and get some light in, some full spectrum light. Or use full spectrum light. Get a full spectrum light box. Turn it on. They're not that expensive. And that will help improve your cortisol awakening response. Why is the car important? It influences a trillion things. It's so important. And unfortunately, in our 2.5 hours, we don't have that much time to go into all of these in great detail, but some of them as we go through and into the cases tomorrow, I will touch on, such as autoimmune, which is my favorite part of the car. We will talk about in the cases tomorrow. But energy levels makes total sense. Stress response, resiliency. Can you make a Mount Hood or not? And how many of your patients come in and maybe they don't use the word resilient, but that's what they want to use and just don't realize it? I don't feel very resilient anymore. I was 10 years ago, and I'm not now. I'm more reactive. I'm more tired. I can't rebound like I used to. That's resiliency. They've lost their resiliency. Their level of feeling stressed out, their level of alertness. Just like I said, the whole point is to switch you from conscious, your eyes are open, to alert in about 20 to 30 minutes. One of my best friends who lives in Arizona is not a morning person at all, in the least. And I've spent the night at his house multiple times, and I am absolutely a morning person. He says, when I come down in the morning, like Cinderella, birds circle around my head. But I'm not allowed to talk to him in the morning because he has not gone from conscious to alert until he's had his coffee, and it takes him about an hour, hour and a half. Then I'm allowed to approach him and talk to him. So he has car problems. Blood sugar management, why does it affect that? Because you've been fasting all night long, right? So you wake up fasting, and you're in your cave, and you gotta go find bugs and berries and kill a bison. So your car is like, I got you. I will maintain your blood sugar balance, no problem. But if you don't have it, if you're not very good, or if it overshoots, you're going to have problems. Mood, anxiety, panic, depression, worry. Autoimmune we'll talk about tomorrow. Inflammatory regulation, big one. When I talked about what does cortisol do, cortisol does a lot for your cytokines. Infection regulation, memory, recall, and cancer outcomes. If you have a flat slope, CAR included, you have worse outcomes. You have to get the collection of the CAR right because you need to get it on waking and 30 minutes later. So when you do this on patients or when you do this on yourselves, don't lay in bed and play on your phone. When you wake up, do the test. 30 minutes, set your timer. 30 minutes later, do the next part. 30 minutes later, do the next part. And you have to impress upon your patients, you're going to spend money on this. So I need you to get it right. And I know it's a lot more the collection and it's kind of overwhelming, but it's more data points. And when we have more data points, I can affect all of these things and help you, help guide you, help give you education. So when we do the collection, if they wake up with the flu, if they wake up super early to catch an airplane or come to a Dutch Fest, it's going to affect their CAR. Don't let them collect on that day. It's amazing to me the number of patients who go, so I have a urinary tract infection, but I went ahead and did the test. Why would you do that? Or I woke up with a fever of 102, but I still wanted to do the test, so I did it anyway. Well, now I can tell you what happens when you have a fever of 102, but when the fever goes away and you're back to your normal self, you have to do the test again. We had a doctor call me the other day, and he said, he emailed me, and he goes, my patient has the most ridiculously high CAR I've ever seen. What is going on? What could it be? This guy is not this way. So I pull his requisition form, because I have access to that, right? Sure enough, in the notes on the second page at the bottom where it says, is there anything else you'd like the lab to know? It says, the night before testing, I broke my arm and spent the night in the ER. Y'all, don't do that. So now I know what his cortisol awakening response is with a broken arm. So we're having him retest in 8 weeks. So, and going back to this example, if your dog wakes you up early in the morning, your CAR is going to be higher. But that point right there, where the red arrow is, the actual CAR, a normal CAR on a normal day, is this really, I know it looks tiny from way back there, but it's this steep incline. It's 30 minutes. You only have 30 minutes out of your 24 hours to get it right. And I know it sounds ridiculous, but it does influence so many things. So really hit home with your patients about how important it is for collection. And for yourselves, it's amazing to me the number of practitioners who call and they're like, so I screwed that up. I'm like, it's okay, we'll just do it again. So get it right. So why measure the cortisol awakening response? Because if you can't get this right, how do you expect to get any of your other stress response right? How do you expect to get it right? So that's why it's really important to know this. If you want to know how resilient you are, what's going on with your mood, your blood sugar, autoimmune, it all ties in. So it's really helpful to know these things. The benefits of the CAR are things when we compare a Dutch complete or a plus, so urine versus the free cortisol and saliva. So in the urine, the B point is the 2 hours later. So the CAR should be in that because you made it 2 hours ago, and then it showed up in your bladder, and then you urinated out. So in this example, the urine patient is on the left, and it's a flat line, but when you add in the CAR, same patient, when you add in the CAR, the person on top is still flat. So that person's flat regardless. They have a low cortisol diurnal pattern regardless. Not healthy, not good for cancer outcomes, not good for cardiovascular. But the person on the bottom makes a mini Mount Hood. It can make a tiny little mountain. So that person on the bottom, that B patient, has more resiliency than the person on top. They need more power. They need to get their CAR up, but they're not as dead as the person on top, which is why you can hone in and figure this out about people. You totally go up. We just need to get you up into the reference range now. Versus the person on top where I'm holy crap, you are flat. You are at a much bigger risk for much bigger diseases, and that's really concerning to me. Or if the person on top, let's say both these people had cancer. They have breast cancer, let's pretend. And the person on both of them, you ran a urine test, and they're both flat, which is bad. Don't get me wrong, that's bad. But when you did a CAR, you can see the A patient with breast cancer might have worse outcomes. The B patient on bottom might have better outcomes because they actually can manifest a diurnal pattern, it's just not that strong. So that might be helpful to know in those cases. When you're below the reference range, this is why we think it's really important to include a reference range with CAR, because yes, the percent incline is really important. Are you at 50%, 100%, 4,000%? That's a really stressed out person. But when you come back down, are you actually in the range, right? Like this example, if you were this person and you just saw, like you incline 50, 75%, you're like, yay, that's normal. But when you look at the blue shaded area is the reference range. And you're like, oh, okay, hold on. You can mount a response. You have some resiliency, but like you're not even in the reference range. So this is why the reference range is so important. It puts you in relation to where they should be. Or what if this mountain, this Mount Hood here, was above the reference range? So their percent incline is still 75%, but they're like way up there. Like, whoa, we need to temper that down. Like, hold on, you got a high CAR. Like, let's simmer that down a little bit. But if you don't know in the reference range, then you're just going to be like, oh, the percent incline is normal. You're normal. And we know they're not. So in this example, we need to give them more power compared to somebody who's flatlined, where I'm going to hit with harder stuff. Here's another example of a high person. So this is a urine and two urines, so A patient and B patient. They look about the same. Their Mount Hood is about the same in urine. We have them do the cortisol awakening response, and you can see the person on top looks about the same. Person on the bottom, though, has this really exaggerated 30-minute point. They probably wake up feeling very stressed out because they have an exaggerated cortisol awakening response. You're probably going to treat them a little bit differently. Their story is probably going to be a little bit different. So you get, like I said, you get this exaggerated response. However, I will say, in full disclosure, sometimes any test will do, right? Sometimes the person can be so on fire that no matter if they do a urine test or a saliva test, they're high. They're blowing up. Like, their CAR is high, their morning is high, everything is high, the person is inflamed and on fire. So in this example, did the CAR add anything to your treatment plan? No, but this person probably came in and told you a million and thens and has autoimmune and everything's on fire and all their serum markers look horrible. So you're like, yeah, like you're on fire. I could tell you this. I know this. So if the CAR is the best test, why should we test in urine? And that brings us to the cortisol metabolites. Cortisol metabolites. And the thing with HPA-Access, as you guys know, is you could probably talk about it for 2-3 straight days, right? And we're just trying to cram the entire top to bottom HPA in about 2.5 hours. But make sure you guys feel supported and have directions on where to go and what to do. So why are the metabolites important? Because they represent about 80% of production. So when patients go, do I even make cortisol? You can look at the metabolites and go, yes, yes you do. Or no, no you don't. And that's what makes it really, really helpful. The free cortisol, as I said, is less than 5%. This study said it's about 1%-ish, which is not a technical scientific term, but you get the point. So it gives us that rough idea of how much you make in your day. And when the free and the metabolized cortisol align, when they face the same direction, if you're familiar with using a Dutch test, when the arrows face the same direction, it's just confirmatory. So when they're both high, you are like, yep, that confirms you're on fire. And everything looks on fire. So this is pattern 1. Everything is high. There are 4 main patterns that you guys who use Dutch often call and ask about. So 4 patterns, we're going to break it down. Everything is high. It's just confirmatory. Free saliva or urine is high, doesn't matter. Metabolites are high, on fire. Pattern 2 is the opposite. Everything is low. Now, not necessarily Addison's, not necessarily at 0 or near 0. For example, this metabolized cortisol is 2,200 and, what does that say? 80, there you go. So it's not near 0, but it's like low enough where you're like, what is suppressing? What is going on? Is this a feedback loop? Are you on opioids? Did you take Accutane? What's going on that is just so suppressive? Pattern 2. So this makes sense. You're like, okay, I know what to do. Everything's really low. But what happens when the direction of the dials don't face the same direction? What happens when one is higher and the other's lower, or vice versa? And this is when you know there's abnormal cortisol clearance or production, but you're trying to figure out why. So that leads me to pattern 3. Pattern 3 is when the dials face each other. So your metabolized cortisol is low. So when the metabolized cortisol is low, and the free cortisol is high. And if you're not familiar with these dials, the star, you read it like a gas gauge. And the one star is the low end and low, and the other star is the high end. So when they face each other like that, then we start to think, okay, sluggish clearance, you can't get it out of the liver, so the free just starts to circulate because it can't get metabolized, right? Nobody's pulling it into the liver to get metabolized. So it's running free like a wild child. The most common reason for this is hypothyroidism, overt or subclinical. We are not a thyroid test. We cannot tell you what the thyroid levels are. That is done in serum. But we can at least point you in that direction of going, hey, have you done a thyroid test on this patient in a while, like a full panel? Because I think something's going on with their thyroid. However, it can also be with abnormal liver function. And it can also be with somebody with a current or long past history of anorexia. Now, the research on anorexia is interesting because I've, absolutely had patients with a history of anorexia, but they don't look like this, and other people who have a long history of anorexia where they do look like this. And so it's not always absolute, but what we think and what we surmise is that when you are anorexic, your body is trying to survive, and so it dials down cortisol metabolism so your free can play longer, right, to help you with survival. Now, you're going to ask, I know, is this the same for like intermittent fasting? Is this the same for time-restricted feeding? Is this the same for people who do the fasting mimicking diet? It depends, and it depends on the length of time, right? If you do a fasting mimicking diet for 5 days, is it going to look like this? Maybe, but homeostasis should rebound once you come out of the diet. I did the fasting mimicking diet for 5 days. Actually, several people at Dutch did, and we did Dutch testing. Did the day before, all 5 days, and 2 days after. It's perks of the job. We do a lot of self-testing. And absolutely, my cortisol was completely affected, and 2 days later, it was back to normal because it was just a transitory thing. But if you are somebody who is anorexic for years, then it can really affect their liver enzymes to affect the metabolism. So what happens if they face the opposite way? What happens if the metabolized cortisol is quite high? What would cause increased metabolism of cortisol? Increased production. So the most common reason for this are obesity. Your fat tissue is its own endocrine-producing gland, right? And it makes cytokines, and it's like angry, and it's not healthy and helpful for you. And you have a lot of this enzyme 11-beta-HSD1 in there that is converting your cortisone to cortisol all in your fat tissue. That gets metabolized out and shows up in the urine. Hyperthyroidism patients. When you have excess of thyroid, then you're going to speed up your cortisol metabolism, and as a result, your free is low because it's getting metabolized so quickly. It's getting made and out, made and out, made and out. Long-term stress, possibly, and possibly with chronic fatigue, but the research is mixed. So we talked about chronic fatigue and cortisol, and in that regard, it's low free cortisol, but the metabolized might actually be high. But it depends on the patient. Nothing's absolute. So in these cases, what are we doing? We're supporting the HPA axis, addressing the cause without trying to be too stimulatory. If somebody's hyperthyroid, I'm not going to slam them with glandulars per se, right? And all this in licorice and maybe even Cortef per se, because they already have an excessive metabolism. I'm going to work on other things and maybe come back to it. Maybe. But so let's talk about thyroid, because this is really, really important. In both of these cases, if you saw this on the saliva or in urine, you might think to yourself, I need to put them on a lot of stimulatory things. I need to put them on licorice. I need to put them on glandulars, heavy doses of adaptogens. If you can prescribe and you feel it's appropriate, maybe Cortef. But what if the top person is actually prednisone suppression and you didn't know it, they didn't tell you, but now that you have the metabolites, you can go, oh, bigger picture, everything's low. Where the person on the bottom, it turns out they were on thyroid medication and being overdosed. This is a real case, the person on the bottom. So they got their Dutch test back, and the practitioner goes, oh, okay, runs a thyroid test in serum and sees that they're in a hyperthyroid state, too much medication. So the person on the bottom is going to adjust the thyroid medication, but if you only focused on the free levels, you might miss this picture. Maybe not, because you're diligent doctors and practitioners, and you're running the follow-up blood work, but by knowing this, you know which rabbit hole you're going down. So how does thyroid directly impact the cortisol? It turns out as someone becomes more hypothyroid, their metabolism decreases, which makes sense. When you become more hypothyroid, everything slows down. You're right, your GI slows down, your metabolism, like your weight goes up, your hair falls out, your skin gets drier, your cell turnover gets slower. Everything slows down, including the production and metabolism of cortisol. So it goes way down. Hyperthyroid's the opposite. Everything speeds up, fast, fast, fast. Therefore, your metabolism goes fast, fast, fast of your cortisol, but your actual metabolism too. Hyperthyroid people often tend to lose weight. So we can see this trend in Dutch testing. So on this low person, this person who looked like this actual patient, the practitioner fixed their thyroid. And here's the other thing that showed up I want to point out. Look at their pattern. Look at their diurnal pattern. It's a flat line. It's a flat line. So you're going to look at that with that free cortisol, and you might think, oh, they have a diurnal pattern issue. I'm going to affect the HPA axis. I'm going to address that first. But by knowing their metabolites are high, they're on thyroid medication, you test them, they're in a hyperthyroid state, this practitioner adjusted their thyroid medication, lowered it, their pattern came back. They have a normal diurnal pattern, up, down. It's a little on the high end, I get it, it rides the upper reference range, but the pattern returns. So what was happening was the hyperthyroidism was masking what was going on in the adrenals in this case. Now this person still's a mess. Everything is still high, don't get me wrong. Their free cortisol is high, their metabolized cortisol is high, but now that you've adjusted for the thyroid, their pattern comes back, you can actually see the true picture of what's going on with their HPA axis. So if you had just looked at the free cortisol above and slammed them with licorice and glandulars and adaptogens and hydrocortisone, but really what they really look like is the person on the bottom, once their cortisol was corrected, now you're going to be able to effectively treat them. Because if you slam them with all the stimulatory stuff not knowing, they're going to call you and say, I have anxiety, I have insomnia, I feel jittery, I feel nervous, I don't like this, I hate this. And you're like, well, I don't understand. Your free levels are low. But it's just having this extra piece of information really just sees the forest through the trees of, oh, thyroid, got it. So thyroid can directly impact cortisol metabolism. So my suggestion when you're doing Dutch testing, I know we talk all the time about how the HPA axis is greatly affected by the thyroid and vice versa, and you should always start with the HPA axis. Treat the HPA axis. I fully believe that. Treat the HPA axis. Dr. Lavelle talked about it, absolutely. But keep in mind, if you have somebody on thyroid, it can absolutely impact the results. So you may end up having to address their thyroid and their HPA axis at the same time, because the thyroid issue could be masking what's really going on with the HPA axis. They still have an HPA axis problem. I'm not debating that at all. But you may need to address both the thyroid and the HPA at the same time. If they're not on thyroid medication or supplements or whatever you have them on, but you see one of these patterns, test them still. Still run a blood test on them and see what their thyroid's doing. I had a practitioner call me, this is a couple years ago, in like November, and she saw the pattern that looked like the top pattern, and she said, why is that cortisol metabolism high? So I was like, it could be obesity, it could be inflammation, it could be hyperthyroid, and the practitioner's like, no, it's not thyroid, I don't think thyroid's the problem. And this is in November. In January, the practitioner called me back and said, holy crap, she was diagnosed with Graves over Christmas. It showed up on the Dutch test. Does it mean like every patient has Graves? No, please, no. Not every patient with high is hyperthyroid, or has, hyperthyroidism. It can definitely be stress, it can definitely be obesity, it can be other inflammation, other things. Just don't rule it out. Don't assume. But we know that the cortisol absolutely impacts the thyroid. They're like bestie friends and arch nemesis at the same time, right? Cortisol will absolutely impact it. It's bidirectional. there are these things called deiodinases. Now, we don't have time to go into thyroid because, yeah, I have like 100 slides to do in 15 minutes. So, but I want you guys to have this information. These deiodinases are what convert T4 into T3 or T4 into reverse T3, and they do it in the periphery or they do it in the pituitary only. And when you have this, cortisol absolutely impacts these deiodinases, and so what happens is you get an increase in reverse T3, which is the middle bullet point, and then you get a decrease in TSH in the pituitary. So the pituitary is like, whoa, cortisol, drop that TSH. They get a blood draw, and they're like, I have all the thyroid symptoms, all of them, and they get a blood draw, and the doctor goes, your TSH is normal. Or maybe it's a little low, or even hyperthyroid in the pituitary because of that deiodinase specific for the pituitary. But out in the periphery, they're in a hypothyroid state because cortisol is interfering with the ability in the periphery to make T3. So just something to keep in mind. Address the cortisol, for sure. Address them both at the same time. They have an impact on each other. All right, obesity. What about obesity and cortisol? So this is actually greater than 5,000 females who've done Dutch testing, and we record the BMI of height and weight of everyone and calculate their BMI. And I know BMI is not like the end-all be-all, don't get me wrong, but we had to start with a point. And so we're looking to try to get some of this published. Some of this is published, and we have the references below. People assume free cortisol increases as BMI increases. And it doesn't necessarily. It's a pretty flat line. But what does increase with obesity and BMI are your metabolites. It impacts your cortisol clearance. So in these cases, definitely address the HPA, but like go for the pillars of health. Work on their central adiposity. Work on those things, and you will see the cortisol clearance start to improve, which is really cool to see over time. So that's the data, the scatter plot on the data, where you can see as the BMI goes up, the clearance goes up as well. So in this example, with obesity, the person on the top actually has CAH. So the metabolized is low, the pattern is low, and but let me go back up. If you're just looking at the low pattern in the low metabolized, this happens to be CAH. What is CAH? Congenital adrenal hyperplasia. As a reminder, we're not going into this. Maybe Dr. Gersh is a little bit with PCOS. But with CAH, what happens is the 21-hydroxylase gets inhibited, and as a result, the arrow goes all the way down to the androgens, and you make a boatload of testosterone. This is an actual case. This is the person's testosterone. But in this example, where they also have a low pattern, their metabolized cortisol happens to be quite high because they're overweight. They have a lot of central adiposity. So if you're just looking at that pattern, you see just a flat pattern, low free cortisol, and you're thinking, I'm going to just pump them up and get that cortisol up there without having that extra metabolite information, like you're missing two separate things, congenital adrenal hyperplasia, obesity, thyroid. So it's really helpful to have that information. I get asked a lot, what supplement do I give with a low metabolized cortisol? Or Carrie, what supplement do I give with a high metabolized cortisol? Like, I don't know. What's the cause? But now you know where to look. Now you're going to go like, oh, she's pattern 3. I better test her thyroid. I'm going to ask her about anorexic history. I'm going to look at like liver detoxification pathways. Oh, he's pattern 4. He has elevated and low free. I got to figure out why he's so fired up. What has increased his cortisol metabolism and production. So now you have just more direction on where to go by having this information. So let's dive into some results. Laboratory assessment. High cortisol. We're going to start with high. We'll talk about high CAR, high PM, and then we'll go to low and walk through that. So everyone thinks I'm overly dramatic when I'm stressed. When an octopus is stressed, it eats itself. Now that's overdramatic. We are talking about a dramatic high cortisol. When it's excited, those of you who've been around a while, or maybe even currently, refer to it as phase 1 adrenal fatigue. Please note, the concept of adrenal fatigue is now HPA axis dysfunction. It starts in the brain and moves down. I understand adrenal fatigue just sounds sexy, but unless it's Addison's, brain. Go for brain. Okay, What's defined as high cortisol? I feel like most all of you know this, right? It's elevated free cortisol in more than 1 point, high across the board. They look really fired up. Their metabolized cortisol is high. Their CAR is exaggerated. They're pretty straightforward. You look at a result, and you're like, wow, that's high. So when you're looking at this on the scale, they follow more on your right side, the adaptive, right? The adaptive high. They're not Cushing's. Well, I'm assuming you've ruled that out. They're not Cushing's. But they're not normal. They're kind of in this like adaptive high side. So adaptive versus high cortisol, how do you tell the difference? Look at the metabolized cortisol. This example, the person's fired up. They happen to have a high afternoon point, which could be situational, but you know overall they're fired up. Their free is high, their metabolized is high, everything's high, what's going on to fire them all up. This person, though, has normal metabolized cortisol. They're not high, they're not low, it's not a thyroid problem, probably. You know, it's not obesity, maybe. Like you're trying to figure it out. But when you look at their pattern, same pattern, they have a high afternoon point. So this is a classic example of when my husband did the test. First and foremost, I feel like the number one rule in medical school should be don't treat your family. Because my husband does this test, and I got the results back, and I'm like, what did you do in the you had one job. All you did was pee on a strip. Like, what did you do? He was like, oh, I was tired. I got Starbucks. Here's the effect of caffeine on you in the afternoon. Like, hello, this is what it's doing to you. So it's just situational. Does my husband have a super fired up HPA axis? No, situationally, caffeine sends him through the roof. And so when you're looking at results and you're like, oh my gosh, his free cortisol's high, look at the graph and go, oh, what did you do? What's going on? What happened? I had a patient years ago who had a high evening, like dinner time cortisol. So what happens? What happens in the like dinner time for you? You know what she said? My husband comes home from work. Sad and funny at the same time. And I was like, I don't have a pill for that. Like, I need to get you a really good counselor because it's affecting your cortisol, and I can see it every single day. So ask your patients, what happened at this time for you? Always address the root cause. In this example, this is a very stressed out, acute, inflamed person. You can see their cortisol awakening response is really high. So you're going to treat. Do you necessarily need to suppress the heck out of their cortisol? Depends on what they're getting inflamed for. Cortisol might actually be helping them, but you're going to sort of support and nourish them all around. How do you do that? You're going to first remember the pillars of health, and you're going to remember everything Dr. Lavelle said, so I'm going to assume you already know that, and this is the next stuff. This is the like, where else can I go? What other Band-Aids can I use? So address the root cause. Lifestyle, he talked about meditation, breathing work, journaling, yoga, heart math, respirate, vagal nerve exercises, increase oxytocin, reduce cell phone EMF exposure. I have a slide on that. And you can do it through the day, in the morning, at night. Whenever you need to do it, you can do it. Now, I fully understand that this is a rat study, and we'd prefer it in humans, but how scary if this would be in humans. They put rats in a cage, turn on a cell phone, into talk mode for 6 hours a day in the cage. You can see in the red circle, ACTH is the left box, plasma cortisol is the right box, and after 1 month, it goes up, and 2 months is the really high black bar of getting the exposure from the cell phone. Again, I get it, small rats, phone, but just think about like our exposure. Maybe consider putting your phone in like airplane mode, turning off your router at night. Don't sleep with your phone in your room, your computer, like put all that in airplane mode. Just something to consider given this study. The other thing they found is that when these rats had a really thickened hypertrophy and disorganization of the fasciculata, it's already 70% of the cortex. And when they got all this exposure to the cell phone exposure and talk mode for 6 hours a day, that it got thicker. That's pretty significant. So just something to keep in mind. What stimulates the vagus nerve? All these fun things. Tell your patients to sing. Tell your patients to hum. Tell them to gargle. Valsalva maneuver. I hate that one, but I had to put it on there anyway. Meditation. Work on the gut. Right? Makes sense. Yoga, rhythmic breathing, as Dr. Lavelle said, and lay on your right side will all help the vagus nerve. The vagus nerve is your big nerve, the wanderer, right? That wanders all through and affects everything through here. Most of its input is 80% of it goes from the gut to the brain, and it's parasympathetic. So it's your big parasympathetic nerve. The other thing is oxytocin. Big fan of oxytocin. Physical touch, words of encouragement and appreciation. Y'all, we appreciate the fact that you are here at Dutch Fest, coming here at 7 in the morning, and I definitely encourage you to like hang in there to the end of the day. You can do it. Boom, your oxytocin is up. Meditation and prayer, eat, drink, and be merry with your friends and family, and breastfeeding. I told you earlier I have 2 slides that are my most favorite slides in the whole world. How else do you get oxytocin up? This is how you get oxytocin up. This is how we do it at Dutch. We're big fans of dogs at Dutch. So Hank on your left is my dog. Ginger belongs to Mark, and Jade belongs to Amy. So we had to put pictures of them because they are the cutest. And once again, your oxytocin is up. Your sympathetic system is now down, so you're welcome. Anytime in this lecture, or this whole class, you feeling sympathetic, just pull the slide up and you're good. How do you support your general HPA access? The general things out there. Now, when it comes to treatment, I have general, helpful snippets on each of them. I know you're not going to give your patient a B vitamin, vitamin C, magnesium, essential fatty acids, every single adaptogen I recommend, every single brain support I recommend. Like, that's stressful just to think about. But you're going to read these and you're going to think to yourself, all right, you know, like they could use some help with more, like relaxation. I'm pretty sure they're magnesium deplete. Or like vitamin C, they're sick a lot. I need to help them with that. And you're going to look at this, and that's how you're going to decide what to give them. Essential fatty acids, which is omega-3s, I don't have any extra information on because I feel like we could do a 2-day lecture on omega-3s alone. So just take your omega-3s, as Dr. Lavelle said. But your B vitamins, specifically B5, pantothenic acid, B6, P5P is my favorite. That's the active form. If you're doing regular vitamin B6, please be careful of neuropathy. Vitamin C is not absorbed very well. It's absorbed better in smaller doses throughout the day. So just something to keep in mind. Humans can't make their own vitamin C. But guess who can make their own vitamin C? Goats. Goats can make their own vitamin C. So it turns out, I did the math, an average 60-pound goat makes about 5,400 milligrams of vitamin C a day. I'm sorry, they put money towards this to study this. And who needs to know how much vitamin C a stressed out goat makes? And how stressed out are goats? Have you seen goats? Like, they're the least stressed out animal ever. And the cutest sound in the whole world are baby goats when they run and they right? Like, it'll raise your oxytocin. I should be a goat researcher. But they make a ton and humans don't, so take some vitamin C. Calming support, GABA. It's your primary inhibitory neurotransmitter in your brain. If they have a lot of anxiety, GABA is a good one. GABA is not thought to cross the blood-brain barrier, but there's a very cool paper. And now that I'm up here, I think I forgot to cite it. I'm so sorry. I will get that to Amy to email that out to you. That said, when you take GABA, it works through the enteric nervous system, and it tells the enteric to tell the brain to make GABA in the brain. And I thought that was really cool. Some lecturers I know talk about leaky blood-brain barrier, and if you take GABA and you feel better, it actually means your blood-brain barrier is leaky. Possible. I don't doubt it, but I also believe in the enteric nervous system, so I'm like, maybe it's a good thing if GABA works for you. Pregnenolone, some of you use pregnenolone. Pregnenolone is very helpful, not in making cortisol, like there's no steel and it's not direct, but it turns into allo, A-L-L-O, and allo crosses the blood-brain barrier, and that's what touches on GABA and is supportive. We have amino acids there that are helpful. L-theanine's probably my favorite. Dr. Lavelle talked about that. Relaxed alertness is what they call it, that it does. So if you've never used theanine, it kicks in pretty quick, and it doesn't make you drowsy, relaxed alertness. It also increases BDNF. 5-HTP and tryptophan affects serotonin. Please be careful if they're on antidepressants. Please be careful of dopamine, which I'll show you. Taurine's not exactly an amino acid. That's why I have it in parentheses. But it's extremely abundant in the brain, very important for the central nervous system. Helps control potassium, sodium, magnesium. All right, dopamine. Remember that tryptophan and tyrosine use the same rate-limiting step. So if you give a whole lot of 5-HTP, then you're going to potentially, at the risk of, deplete dopamine. So just be careful with how long you use 5-HTP. Calming support, this is specifically for 11-beta-HSD1. 11-beta-HSD1 is where you make more cortisol. So these are the herbs shown in research that actually help calm them. Unfortunately, in the interest of very little time, I am so sorry. We're going to speed through the treatment part. but I just want to point out Magnolia, make sure the hinocchiols are greater than 90%. I use Magnolia a lot for a high 11-beta HSD1. That works really, really well. Ziziphus is jujube, great for if you can't sleep through the night. It's often in through the night supplements. General calming herbs, chamomile, milk avena, so oats, right? Passion flower, which is often compared in some research to benzos. So Xanax or passion flower. Passion flower is pretty helpful. And then hemp-derived CBD, which is its own module lecture unto itself. Good research on anxiety, though, for that one. Your adaptogens. Dr. Lavelle talked about several of these. They're in his notes as well. I have some information. Some of them increase BDNF. They work on the immune system. They work on the brain. They work all over. It's why they're called an adaptogen. These are generally the least stimulatory adaptogens. Like Panax is an adaptogen, red Panax, but it can be very stimulatory for people. Be careful of rhodiola. It can be very stimulatory for some people, depending on your dose. Rhodiola can also be drying, according to some herbalists that I've heard talk, so be careful of dry eyes, dry mouth, but really good for the night sweat, hot flash type woman. And then we got cordyceps, which of course is amazing, stamina, improve physical health. Shishandra, I had an herbalist in medical school who said this about Shishandra. She said, if you are a woman and you have PMS, or you are a perimenopausal or menopausal woman and you are angry, that Shishandra's for you. So it's the angry woman that works so well for Shishandra. And then we have, of course, Bacopa. All right, BDNF, I told you I had ways to help improve BDNF. This is a cool study. This is their graphic, of course, on the adaptogens and herbs that help raise BDNF. Not all of them have a lot of research behind them, and they even admitted that in their study. They said Panax has the most research behind it. Eleuthero and ashwagandha have the least, but they're still helpful. What also increases BDNF? Exercise, deep sleep, regular enjoyable socializing. So on the breaks and at lunch, like meet your neighbor. Do some enjoyable socializing, and your BDNF will go up. Zinc, mag-threonate in particular. I haven't seen research on glycinate, but I have on threonate, so just keep that in mind. Omega-3s, DHEA, which we'll talk about tomorrow, apparently, niacin, and then magnolia, my favorite for 11-beta HSD1. All right, so CAR. Anything you do with a high CAR, do it within 30 minutes. That's my key takeaway. If they have a high CAR, any of the breathing, the meditation, the herbs, whatever you do it in the first 30 minutes of waking up, because you're trying to impact their cortisol awakening response, and it happens in that first 30 minutes. So do it in that first 30 minutes. Also make sure you address their sleep. Sleep has a massively huge impact on the cortisol awakening response. High PM cortisol, very, very similar to everything else. If they have high PM cortisol, inflammation with high PM cortisol, as cortisol naturally decreases, your inflammatory response goes up. Have you ever gotten a fever and it went away in the day and it came back at night? Or you got a sore throat and it went away in the day and came back at night? This is one of the mechanisms. So as it goes down, the inflammation comes back, and now your cortisol goes back up to combat that. And now you have insomnia and you can't sleep and you still don't feel good. So just keep that in mind. But also keep in mind if the cortisol is high to protect you. Is it combating the fever? Is it combating the sore throat? Just, keep that stuff in mind. So if you know the cause of the inflammation, address it, especially at night. Is it parasites? Go for that. So PM cortisol, obviously, it's the things that we learn over and over and over in functional medicine. Wear your blue light blockers. Wind yourself down at night. Get off your screen. Avoid caffeine. Be careful of stimulatory exercise. Those kind of things. Anything that will drive up the HPA axis. Friendly little reminder on caffeine and what it does with adenosine. It's an opposite for adenosine. Adenosine is what makes you feel sleepy. Caffeine is an anti-adenosine. So if you take caffeine, you're like the party animals over there, and you can stay up. Fine at 10 in the morning when you're not alert, not fine at 10 at night when you're trying to go to bed. So calming support, phosphatidylserine, probably one of my favorites. I'm sure a lot of you use phosphatidylserine because major phospholipid class, important for so many things in the brain, and important for reducing ACTH, therefore reducing cortisol. It's used, you can use it in the day, absolutely. I tend to use it more at night because it has the sleep effects. Magnesium and GABA we talked about. Amino acids we talked about. Those we talked about. Tulsi is probably my favorite adaptogen ever, especially for high cortisol. I drink holy basil tea, which is Tulsi, every night before bed, every single night. Low cortisol. We'll go through this, and then Dr. Evans will talk. So burnout, right? We got to avoid burnout. We don't want to be like Frank, who just up and exploded. So let's move into treatment. Because you understand, to address the root cause, it's very important. Hippocampus is what controls your cortisol awakening response. PTSD affects car, and fluorescent lights will affect your car. So causes of hippocampal damage, common things we've talked about, right? Diabetes, stress, PTSD, depression, things like that. Always remember the feedback loop. Maybe they're in your office. They had high cortisol their whole life, and now they're at the low point. So remember that you may be at the end of the spectrum for them. All right. So it goes up to high. Feedback loop kicks in. We're down to low. Treatment considerations. All right, low cortisol, HPA retraining. This is what I call uppers in the morning, downers at night. I don't mean that in the illegal way. I mean that in the supportive adrenal way. We want to have our cortisol come up in the morning and our cortisol go down at night so we can sleep, right? Using your adaptogens, using your nutrients, using your brain support, using your light therapy, modulation, very important, especially if you live in the Pacific Northwest. And doing movement and exercise in the morning impacts the car significantly if you do it right on waking. So I've said it all starts in the brain. We talk about adrenal fatigue, and the adrenals aren't like the ovaries. They don't just give out in menopause, unless you have Addison's. But it starts in the brain. So you have to improve blood flow and oxygen up to the brain so that you can get all those hormones to communicate with each other and move downstream. So how do you do that? Exercise, right? Stop smoking. It's amazing to me when I see people who smoke. I'm like, you still do that? That's still around? Oh my gosh. Don't you know anything? Normalize your blood sugar. Neurofeedback, biotuning, cranial sacral work, energy medicine, acupuncture, chiropractic, anything that affects the muscles and the joints and the flow and the chi will help with your blood flow and your oxygen, which is fantastic. Test them for hemochromatosis, especially in men. Men can get hemochromatosis. They get forgotten. I had plenty of men in my practice. Sent him to a hematologist who was like, holy crap, why do you have so many men with hemochromatosis? I'm like, why are you not testing? Super common. More common than I thought, I should say. It's not super common. It's more common than I thought. But the iron deposits get on and affect the brain. And then, of course, the cell phone. You saw the rat study. Please don't sleep with your phone next to your bed unless it's in airplane mode. How do you support the brain? Bacopa is one of my absolute favorites for brain support. Increases BDNF, decreases hyperactivity, increases attention. Good for those ADD people. Cordyceps is my other big favorite. I love cordyceps. I can't find the study, but I have found a study where it works on improving pituitary, improving ACTH. Omega-3s and rosemary. Rosemary, okay, you guys, has cognitive enhancing powers. I could use cognitive enhancing powers. We should have had rosemary in here at 7 o'clock in the morning, and you all could have or diffuse rosemary oil through the whole room, right? It does so many things. Antioxidant, increases NRF2, super important for your phase 2 detoxification. Protects against LPS damage. Rosemary, that's amazing. Anti-inflammatory, inhibits TNF-alpha and IL-6, increases acetylcholine. Acetylcholine is my favorite neurotransmitter. I love acetylcholine. And unfortunately, though, it will suppress iron absorption in the gut. So don't take your rosemary at the same time you take your iron supplement. Ginkgo. I know there's hit or miss on ginkgo, right? Some people are like, oh, ginkgo was hot for a while, and then it's like, the research didn't really pan out. But it does improve recall, recognition, reaction time, and tension. It can increase BDNF. Is it the most potent thing? I don't think so, but it is definitely helpful. PQQ. How many of you have tried or used or heard of PQQ? Yeah, a good handful of you have really helped look at PQQ. I actually don't know how to say the actual name for it, so we'll just call it PQQ. Increases nerve growth factors, protects against NMDA receptors. Antioxidant to peroxynitrite, that's bad. Peroxynitrite is bad because you want to improve your mitochondrial health. Reduces C-reactive protein. That's big. And reduces IL-6. Major pro-inflammatory, right? And then maca. I already said that maca, in an earlier slide, maca reduces ACTH, thus reduces cortisol. Maca also will affect your hypothalamus and pituitary, and thus cortisol, like I said. And then it has the antidepressant effect in your brain. So maca is a really good one. And of course, maca is used a lot for hormones too, sex hormones. Low cortisol, what else do we use? The same basic support. You need B vitamins, you need vitamin C, you need magnesium, and you need essential fatty acids. These are like your core basics for a lot of people who are so deplete from their diet, from the soil, from the choices they make, their crappy absorption. a terrible gut, like these are kind of your core basics, whether they're high or low. But if they are low, definitely look at your adaptogens still. Ashwagandha, Siberian ginseng, rhodiola. Now, the one thing I forgot to mention earlier with ashwagandha is be careful in your hyperthyroid people. It's not indicated for Graves' disease. It can stimulate the thyroid. It is generally considered safe, though, for Hashimoto's. Generally considered safe for Hashimoto's, which is great. Careful of Graves'. Then we get, and again, cordyceps, Shishandra. Are they angry? Give them Shishandra. Tell them to eat the berries. Dr. Lavelle talked about goji berries. I'm all about Shishandra berries. Like, let's not be angry. And then Bacopa again. And then the big stimulatory ones, your Panax, your red ginseng, really, really strong. Love it. Licorice. Licorice takes cortisone and turns it into cortisol. That's why we use it. You have to be very careful, though, with Panax. I have found some women, it will make their, like, hot flash. It makes them hot. So if she's already a hot woman or a hot man, be careful. And licorice, be careful of hypertension and low potassium. I've heard multiple herbalists tell me they've never had a hypokalemic patient on licorice. I have had 2 in my practice because of licorice. Either too high of a dose and they didn't stop, or they put themselves on it and didn't stop. And they dropped their potassium. They ended up in the hospital. I have had herbalists say, though, that licorice is a really great harmonizer. It's a harmonizer herb. So you will often see it in a lot of herbal blends, even the supplement companies here, at low doses, 20 milligrams, 50 milligrams, because it helps the herbs communicate with each other. That's what they say. So when you see it in things and you're like, I don't want licorice, this is crazy. A lot of these companies obviously have botanical experts on staff, and they feel this way. They feel like it's a good harmonizer. So just keep that in mind. Glandulars. How many of you use adrenal glandulars in your practice? How many of you are afraid of using adrenal glandulars in your practice? So adrenal glandulars, there's not hardly any research at all on it, on using glandulars and what they do. But I will say I do. I use adrenal glandulars. I use them regularly. I do use them in the very depleted person, though, who has really low vitality. I find that at work, they work really, really well. And I am careful. I'm careful of insomnia, and I'm careful of anxiety. They are glandulars. If they are a vegan or a vegetarian, they can't do glandulars. Just remind them that, like, it is a glandular. Although, oddly enough, it's amazing when people will, I've had vegans who will go, well, I'll take it for my health. I feel that bad. I will take it for how I feel. But not all. We definitely have to, do other things. Some of you, how many of you use Cortef or hydrocortisone in your practice? So that's a whole other lecture onto itself as well, but it is an option. We're unfortunately, really don't have enough time to talk about that today. So let's talk about a low carb, and we'll just wrap up so Dr. Evans can talk. So low carb consideration, again, do it within the first 30 minutes. Do it within the first 30 minutes, whatever they do. You're trying to get their car up, so get them up within the first 30 minutes. Any of those herbs, any of those nutrients, any of those things, they got 30 minutes. Get sun or full spectrum light within the first 30 minutes. Have them go buy a full spectrum light bulb. Have them open up the curtains. Get exposure to some sunlight for a little bit. Get that SCN stimulated in the brain, through the retina into the brain, so that their car goes up. Speaking of light, I was reading this study, and I was all excited, highlighting, until I got to the red part that says 10,000 lux has a suppressive effect on cortisol. And I was like, what? No, no. And then I read it deeper, and I found out they are using fluorescent lights. Right, like the common kind that a lot of us are exposed to. So I was really psyched. There's no fluorescent lighting in here. Exposure to fluorescent lights more than 6.5 hours a day greatly suppresses cortisol. So in case you don't realize what full spectrum light is, this is full spectrum lighting. That is fluorescent. There's a big difference. Now they will talk about full spectrum fluorescent, that is full spectrum. They do have all the colors. They're just not big and bold and bright like the sun. So just something to keep in mind.